when we talk about medical diagnoses, I think there's this expectation of precision, you know?
Oh, absolutely. Like a clear-cut answer.
Right. Like if a patient breaks their arm, an X-ray shows a jagged white line, the doctor points to it, and the path forward is just obvious.
Yeah, it's visible, it's binary, it's comforting, really.
It is deeply comforting.
Yeah.
But stepping into the world of severe endocrine emergencies, which is exactly what we're unpacking in today's deep dive, it completely shatters that illusion of precision. So, welcome. Today we are diving into thyroid crises. And the absolute most critical realization, like right out of the gate, is that you cannot diagnose these life-threatening extremes with a lab test.
Which is wild, right? It forces clinicians completely out of their comfort zones. I mean, a patient who is actively dying from a thyroid crisis might have the exact same thyroid-stimulating hormone or free T4 levels printed on their chart as a patient who's just sitting comfortably in an outpatient clinic.
Wait, really? The exact same numbers?
Literally the same numbers. The lab values just confirm there is an underlying thyroid disorder. But they are completely incapable of telling you whether that patient's body is compensating for the disorder or actively collapsing from it.
Wow. Which means the clinician standing at the bedside basically has to rely on the actual physical presentation of systemic organ failure.
Exactly. You have to look at the patient, not just the paper.
So our mission today for you, the listener, is to map out the two lethal extremes of this spectrum. So we've got thyroid storm and Myxedema Coma.
Right.
And to do that, I think we need to bypass the basic intro biology and look at how thyroid hormone operates on a cellular level, specifically regarding the sympathetic nervous system.
Right. Yeah, that's the core first principle here. So the foundational mechanism is that thyroid hormone essentially sets the basal metabolic rate for the entire body, but it does so in this highly synergistic way with your catecholamines.
Meaning like epinephrine and norepinephrine?
Exactly. Adrenaline. Thyroid hormone actually upregulates the expression of beta-adrenergic receptors on the surface of your cells, particularly in the heart and the nervous system.
Okay, so it builds more receptors.
Right. When thyroid hormone levels are normal, this keeps your cardiovascular and nervous systems appropriately responsive.
Got it. So if we think about the overarching analogy for this deep dive, if the human body is a car, thyroid hormone is basically the accelerator pedal.
That is a perfect way to look at it.
Okay, so let's look at the hyper-extreme first, thyroid storm or thyrotoxic crisis.
Yeah.
This isn't just an overactive metabolism. Because of that upregulation of beta receptors you mentioned, the patient's cells become wildly hypersensitive to normal baseline levels of circulating catecholamines.
Yes, the body is essentially flooded with fight or flight signals that it just cannot ignore. It pushes the whole physiological process into absolute overdrive.
Right. So going back to the car analogy, it's like running a car engine at 10,000 RPMs while it's just parked in a hot garage. Eventually, the cooling and fuel systems just fail.
That is exactly what happens. Translating that cellular chaos to the actual bedside, you see a cardiovascular system rapidly exhausting itself. I mean, the heart rate frequently exceeds 140 beats per minute.
Oh, wow.
Yeah, and it commonly devolves into atrial fibrillation. The heart muscle is attempting to meet this impossible metabolic oxygen demand, and it simply cannot sustain that stroke volume.
So it just gives out.
Left unchecked, yeah.
Yeah.
It rapidly progresses into high-output heart failure.
And coupled with that cardiovascular failure is a profound thermoregulatory collapse, right? Because routine hyperthyroidism might make a patient feel uncomfortably warm, but a true thyroid storm frequently produces a raging fever.
A really high one.
Yeah. The source is a core temperatures easily exceeding 104 degrees Fahrenheit or 40 degrees Celsius.
And that hyperthermia is a primary differentiator. When you are trying to determine if a patient has crossed the line from just severe hyperthyroidism into a literal storm, the fever is a massive clue. And parallel to the fever, the central nervous system is equally overstimulated by that beta receptor upregulation. You'll see severe agitation, intense tremors.
Because the brain is just starved for oxygen.
Exactly. As the metabolic demand outstrips oxygen delivery to the brain, that agitation deteriorates into frank psychosis, stupor, and ultimately coma.
The literature also highlights a very specific gastrointestinal presentation that feels like a crucial warning sign to me. Beyond the severe nausea, vomiting, and diarrhea, the appearance of jaundice, the yellowing of the skin and sclera, that is a massive red flag.
Oh, it's ominous. Jaundice in this setting is an indicator of hepatic hypoperfusion.
Meaning the liver isn't getting enough blood.
Right. The liver requires a massive amount of blood flow to function properly. In a thyroid storm, the liver's metabolic demand skyrockets, but that failing tachycardic heart we just talked about cannot deliver adequate oxygenated blood to meet that new baseline.
So the liver tissue begins to essentially suffocate.
Exactly. It leads to acute hepatic injury. When you see jaundice, you know the patient is spiraling toward multi-organ failure.
God, understanding this physiology makes the historical context of this disease incredibly grim. Like, I was looking at the notes, and before the modern era of pharmacology, surgeons were attempting to operate on patients with highly volatile, overactive thyroid glands like those with Graves' disease.
Ooh, it was a nightmare.
Yeah, the surgical mortality rates prior to the 1920s were just catastrophic. A patient would undergo a thyroidectomy, wake up, and immediately crash into a hyperthermic delirious storm, and they'd often die within 48 hours.
Surgeons of that era were essentially operating on a hormonal powder keg. I mean, just the physical manipulation of the gland during surgery would squeeze massive stores of preformed hormone directly into the bloodstream of a patient who was already deeply thyrotoxic.
So just touching the thyroid was killing them.
Literally. But the breakthrough came from the Mayo Clinic in the 1920s. A doctor named Henry Stanley Plummer hypothesized that pre-treating these surgical patients with a high dose of iodine, specifically Lugol solution, would temporarily calm the gland.
Which seems highly counterintuitive, right? Since iodine is the primary building block of thyroid hormone. But Plummer found that delivering it in a massive acute pharmacological dose actually halted the gland's activity long enough to safely perform the surgery.
Yeah, it's a brilliant hack of the body's own regulatory system. We'll explore the specific mechanism behind that shortly because it remains a foundational pillar of how we actually treat these patients today.
Right. But knowing that this is a well-documented, highly lethal emergency, it is deeply unsettling to look at modern diagnostic protocols. Like, if you are an ICU physician looking at a decompensating patient, you are forced to navigate two distinct and sometimes totally conflicting medical scoring systems.
Yeah, it's a huge debate. Clinicians have spent decades trying to quantify this crisis to avoid relying purely on gut instinct.
So wait, if I'm reading this right, if this is a life or death emergency, how can two different medical scoring systems disagree on whether someone actually has it?
Well, because it's a clinical diagnosis, not a binary lab test. The Birch-Wartofsky Point Scale, or BWPS, introduced in 1993, is the most recognized framework. It assigns numerical values to the severity of organ dysfunction.
Like points or symptoms.
Exactly. A fever of 104 degrees earns more points than a fever of 101. Atrial fibrillation earns points, as does the presence of jaundice or severe central nervous system agitation.
Okay, and a cumulative score above 45 strongly suggests a thyroid storm, while a score below 25 suggests an uncomplicated thyrotoxicosis. And this is the crazy part that leaves a massive ambiguous gray zone between 25 and 44.
Right. And to complicate the landscape for the clinician even more, the Japan Thyroid Association, or JTA, published a competing set of diagnostic criteria in 2012.
So you have two rule books.
Yeah, and the clinical reality is that in borderline cases, the BWPS and the JTA criteria do not always align. A patient might meet the threshold for a stone on one scale, but not the other.
Which places the physician in a highly precarious position.
Extremely. Because the pharmacological intervention for a thyroid storm is aggressive, it uses multiple high-risk medications. Administering that cocktail to a patient who doesn't truly need it can cause significant harm.
But withholding it from a patient in a true storm guarantees their death.
Exactly. It requires immense clinical judgment to operate in that diagnostic gray zone.
Wow. Okay, so when you consider how catastrophic that hypermetabolic state is, you might assume the opposite extreme would be less volatile, just a general powering down. But withdrawing that metabolic drive entirely is just as lethal.
Oh, absolutely.
Which brings us to the exact opposite end of the physiological axis, Myxedema Coma, the decompensated extreme of hypothyroidism. And this is most frequently rooted in neglected Hashimoto's thyroiditis, right?
Correct. If a storm is an engine tearing itself apart at maximum RPMs, Myxedema coma is the systemic failure that occurs when the engine is completely starved of fuel. The presentation is virtually a mirror image of the storm.
So everything slows down.
Drastically. Those beta-adrenergic receptors we discussed earlier, they are now profoundly downregulated. The heart becomes highly unresponsive to catecholamines, resulting in severe bradycardia.
So a dangerously slow heart rate. And the respiratory drive is similarly blunted. I was reading that the patient literally loses the neurological impulse to breathe deeply or frequently.
Yeah, they just forget to breathe, essentially. This hypoventilation leads directly to hypercapnia, which is a dangerous retention of carbon dioxide in the blood, and that further depresses their central nervous system.
But the loss of thermoregulation is arguably the most striking clinical feature, I think. Without thyroid hormone driving cellular metabolism, the body just ceases to generate adequate heat. You will frequently see core body temperatures drop below 90 degrees Fahrenheit or 32 degrees Celsius.
It's basically severe spontaneous hypothermia. Accompanying this is severe hyponatremia, low sodium, driven largely by a decrease in the glomerular filtration rate.
The kidneys just stop filtering.
Pretty much. The kidneys simply lack the metabolic pressure required to excrete free water, so they just dilute the sodium concentration in the blood.
Okay, looking at the terminology here, Myxedema Coma is deeply entrenched in the literature, but it feels like somewhat of a linguistic trap. I mean, the term myxedema literally means mucus swelling, right? Coined back in 1877.
Yes, by a committee chaired by William Miller Ord following observations by William Withy Gull in 1873. They were describing this mucin-infiltrated, non-pitting edema that gives these patients a characteristically puffy appearance.
But I want to clarify a massive misconception here. Does the patient actually have to be in a literal coma? Because the word coma feels highly misleading for modern diagnostic purposes.
It is a dangerous misnomer, a huge historical holdover. By the time late 19th century physicians identified this syndrome, the patients were inevitably in end-stage profound unresponsiveness.
Right, they caught it too late.
Exactly. Waiting for a patient to slip into a literal coma today before initiating aggressive treatment is a near guaranteed way to ensure a fatal outcome.
So what does it actually look like?
The condition represents a spectrum of altered mental status. It starts with lethargy, confusion, or profound psychomotor retardation, well before eventually deteriorating into true unconsciousness.
And the neurological exam for these patients yields a highly specific finding known as hung-up reflexes, which I found fascinating because it provides a brilliant window into the cellular physiology.
Oh, it's a classic sign.
Yeah, so when you strike the patellar tendon, the leg kicks out normally, but the relaxation phase is bizarrely delayed. It's just slow to release.
And the mechanism there directly illustrates the cellular energy deficit. To relax a contracted muscle, the muscle fibers actually have to pump calcium ions back into the sarcoplasmic reticulum,
which takes energy.
Right. That process requires a constant supply of ATP. Because a myxedema patient lacks the thyroid hormone required to drive ATP production, the muscle simply does not have the cellular energy required to execute that relaxation phase efficiently. The reflex visibly hangs up.
That makes so much sense. To make this memorable for the listener, the classic demographic profile you encounter in the case literature is incredibly consistent. If you're looking out for this presentation, you are generally looking for a textbook example of an elderly female patient with a history of neglected hypothyroidism.
Right.
She's typically found profoundly hypothermic in her home during the winter months. And very often, the precipitating event was the introduction of a new medication, like a sedative or an opioid, which suppressed her already fragile respiratory drive just enough to tip her into respiratory failure.
And that concept of a precipitating event is vital. I mean, neither of these crises typically occur spontaneously in a vacuum. A patient might walk around for years with poorly controlled thyroid disease, just hovering right on the edge of the cliff.
But it requires a distinct physiological stressor to push them over the edge. Which brings us to the sneaky triggers of crisis.
Yeah, the mundane medical events that act as catalysts. In the case of a thyroid storm, that precipitating stressor is usually a massive systemic insult. Severe infection, physical trauma, childbirth, diabetic ketoacidosis, or, as we mentioned earlier, undergoing surgery without appropriate endocrine blockade.
And for myxedema coma, the stressors include prolonged cold exposure, acute myocardial infarction, a stroke, or frequently just an interruption in their thyroid replacement therapy.
Yeah, missed pills are a big one.
Like a patient might be admitted to the hospital for an entirely unrelated orthopedic issue, their levothyroxine gets missed in the shuffle of inpatient orders for a week, and their hormone levels slowly drain away until they decompensate.
It happens more often than you'd think.
But okay, the most fascinating and terrifying trigger detailed in the sources is the Jod-Basedow phenomenon. Are you telling me that a routine CT scan with IV contrast, like for suspected appendicitis, can accidentally trigger a deadly thyroid storm days later?
I mean, yes, absolutely. It perfectly illustrates the danger of treating the body as a collection of isolated systems.
Does that even happen?
To understand why, you have to look at the pharmacology of IV contrast dye. It carries a massive iodine load.
Okay.
If a patient's thyroid is healthy, They process and clear that iodine without issue. However, if a patient unknowingly harbors an autonomously functioning thyroid nodule, like a toxic multinodular goiter or a solitary hot nodule, that tissue is essentially a rogue factory operating entirely outside the control of the pituitary gland.
So it's just making hormone whenever it wants.
Right, but it's usually limited by the natural availability of dietary iodine in the body.
Oh, I see. So when you inject that IV contrast, you're basically dumping a massive shipment of raw material directly onto the factory floor.
Exactly. The autonomous nodule immediately utilizes that iodine load. It rapidly organifies it to synthesize and release a massive surge of thyroid hormone. So days after the patient is discharged with a clear appendix, they are rushed back to the hospital in atrial fibrillation with a 104-degree fever.
That is terrifying. It just underscores why understanding a patient's baseline endocrine history fundamentally alters the risk profile of even seemingly routine radiological procedures.
It's critical.
Okay, moving into the clinical management of these crises, this is where instinct will get you into trouble. Because the intuitive treatments are almost all wrong. The pharmacological protocols are essentially a minefield of physiological paradoxes.
Yes. These scenarios demand a deep comprehension of pharmacokinetics because standard symptomatic treatments often backfire catastrophically. Let's look at the bedside traps.
Let's start with the fever trap. Say you're managing hyperthermia in a thyroid storm. If a patient is burning up with a 104-degree fever, the immediate instinct is to administer a salicylate, like aspirin.
Right, but doing so in a thyrotoxic crisis can be fatal.
Why? Aspirin reduces fever.
It does, but you have to consider how thyroid hormone travels through the vasculature. The vast majority of circulating T4 and T3 is bound to transport proteins, primarily thyroxine-binding globulin, or TBG.
And while it's bound, it's inactive.
Right. Exactly. Only the tiny fraction of unbound, or free hormone, interacts with cellular receptors to drive the hypermetabolic state. Aspirin fundamentally alters this dynamic because it has a high affinity for those same transport proteins.
Oh no, so it aggressively competes for the binding sites.
Yes. It physically displaces the thyroid hormone. If you administer aspirin, you suddenly flood the patient's bloodstream with active free hormone, dramatically worsening the storm.
So it pours fuel on the fire.
Exactly. Acetaminophen must be used instead. It achieves antipyresis without displacing the hormone.
Wow. Okay, and the instinctual trap is equally dangerous on the hypothyroid side. The rewarming trap. If a Myxedema Coma patient is brought in with a core temperature of 90 degrees Fahrenheit, the intuitive response is to utilize active rewarming techniques, forced air warming blankets, heated 5E fluids, just to raise their temperature as quickly as possible.
Which will reliably trigger cardiovascular collapse.
Wait, why? They're freezing.
They are, but you have to picture the state of their peripheral vasculature. Due to the profound hypothermia, their blood vessels are maximally constricted to shunt blood to the core organs. Their bradycardic, failing heart is barely generating enough cardiac output to maintain blood pressure, even with that intense peripheral resistance.
So if you actively and rapidly heat the skin,
you force widespread peripheral vasodilation, the vascular space suddenly expands massively, vascular resistance plummets, and the weakened heart cannot increase its output to compensate.
the bottom falls out.
The patient will suffer immediate profound hypertension and likely arrest. The standard of care demands passive rewarming, literally just using standard blankets in a warm room, allowing the core temperature to rise slowly as the thyroid replacement therapy begins to take effect.
That is such a crucial trap to avoid. All right, what about the order of operations trap? Earlier, we established that administering a massive dose of iodine like Lugol solution is highly effective at shutting down the overactive gland in a storm. This relies on the Wolff-Chaikoff effect, right?
Yes. The Wolff-Chaikoff effect is a brilliant auto-regulatory defense mechanism. When the thyroid follicle is exposed to acutely elevated levels of inorganic iodine, it transiently inhibits the enzyme thyroid peroxidase.
Which effectively shuts down the synthesis of new thyroid hormone.
Temporarily, yes.
But I want to stress the timing here, because the timing of that iodine dose is everything. You absolutely cannot administer the iodine before you have given an antithyroid drug like a thionamide medication, propylthiouracil, or methimazole to block the gland first.
Never. If you hang the iodine IV bag first, you provide the overactive gland with an abundance of substrate before the inhibitory effect can take hold.
Right. The gland will just use that iodine to manufacture a fresh wave of hormone, fueling the crisis.
Yeah.
So the strict protocol is to administer the blocker, wait at least an hour for the biochemical blockade to establish itself, and only then administer the iodine.
Exactly. And the choice of that blocking agent introduces one of the most difficult ethical and clinical tensions in endocrinology, the PTU paradox.
Okay, break that down for us.
Well, in a severe thyroid storm, propylthiouracil, or PTU, is often favored over methimazole. Both drugs block hormone synthesis within the gland, but PTU has a critical secondary mechanism. It inhibits the enzyme 5-deiodinase in the peripheral tissues.
Meaning it stops the body from converting the relatively inactive T4 prohormone into the highly potent active T3 hormone out in the liver and kidneys.
Right. That dual-action blockade gives PTU a massive mechanistic advantage in quickly bringing the hypermetabolic state under control.
But here's the catch. PTU carries a severe FDA black box warning for fulminant hepatotoxicity. It can cause catastrophic liver failure, sometimes requiring an emergency liver transplant.
It's a huge risk.
Wait, didn't we just establish that a severe thyroid storm causes hepatic hypoperfusion, leading to jaundice and acute liver injury? So we are giving a liver-toxic drug to treat a condition that is already actively destroying the liver.
I know. It's an agonizing paradox at the bedside. It is the ultimate clinical trade-off. There is no perfectly safe option here. The physician must weigh the imminent certainty of death from the unchecked thyroid storm against the secondary pharmacological risk to the hepatic system.
You are forced to accept the risk of hepatotoxicity, because if you fail to break the storm, the patient's liver and every other organ will fail anyway.
Exactly. It's choosing the lesser of two very bad evils.
Now, we see a similarly high-stakes debate in the resuscitation of Myxedema Coma patients regarding thyroid hormone replacement, the T3 versus T4 debate.
Yeah, whether to administer intravenous levothyroxine, which is T4, or liothyronine, which is T3. Levothyroxine is a prohormone. Under normal conditions, the peripheral tissues convert it into active T3 over several days.
But in a severe myxedema state, the enzymes responsible for that conversion are profoundly suppressed.
Yeah.
So administering standard T4 means you might be waiting days for the patient to actually generate enough active hormone to reverse the coma.
Right. So from a purely mechanistic standpoint, administering intravenous T3 directly bypasses that stalled conversion process. It provides immediately active hormone to the starving cells.
But T3 is incredibly potent. It acts with massive rapidity.
Extremely fast. If you administer a bolus of T3 to an elderly patient with silent underlying ischemic heart disease, you will instantaneously drive up the myocardial oxygen demand. Their coronary arteries may not be able to deliver the necessary blood flow, and you can easily trigger a fatal heart attack or a lethal arrhythmia.
So the medical community is split on this.
Completely divided. Some protocols mandate slower, safer T4, while others advocate for cautious, low-dose T3, or a combination of the two. It is a precise titration of metabolic recovery against cardiovascular tolerance.
Okay, one pharmacological intervention that remains universally consistent across both extremes is the administration of stress-dose corticosteroids, specifically hydrocortisone. Whether the patient is burning up in a storm or freezing in a coma, steroids are administered immediately. Why is that?
This targets a secondary but equally lethal physiological vulnerability. The hypothalamic pituitary adrenal axis is deeply intertwined with thyroid function. In a thyroid storm, the hypermetabolic state rapidly accelerates the clearance and degradation of the body's natural cortisol.
So they burn through their stress hormone.
Fast. The adrenal glands simply cannot synthesize cortisol fast enough to keep up with the metabolic burn rate, leading to a relative adrenal insufficiency.
And in Myxedema Coma, the severe autoimmune disease that destroyed the thyroid Hashimoto's can often coexist with autoimmune adrenalitis, conditions like Schmidt syndrome or Addison's disease.
Exactly. So if you begin aggressively treating the myxedema by ramping up their cellular metabolism with thyroid hormone, but their adrenal glands are destroyed and incapable of mounting a cortisol stress response, you will precipitate an acute Addisonian crisis.
Right. Without adequate cortisol, the vascular system loses its tone, resulting in refractory shock. Therefore, we never wait for cortisol lab results in these emergencies. We administer empirical stress dose hydrocortisone to safeguard the adrenal axis while we stabilize the thyroid axis.
It's an absolute must in both protocols.
Wow. Okay, so synthesizing this incredibly complex physiological web into a mental toolkit for you, the listener, the vital takeaways are clear? Remember that a lab printout cannot diagnose a thyroid storm or a myxedema coma. You must look past the numbers and evaluate the patient for systemic organ failure.
Look at the whole clinical picture.
Right, and watch out for the deadly traps. No aspirin in storms, no rapid active rewarming in myxedema, And always block the thyroid factory with a thionamide before you flood it with iodine.
It demands a rigorous understanding of the underlying cellular mechanisms, really, because in these extremes, you're not just treating symptoms, you are attempting to manually override a collapsing metabolic engine.
Which leaves us with a final provocative thought to mull over. We are heavily conditioned to view medical emergencies as acute, sudden events. A heart attack, a ruptured aneurysm, a car crash.
Right, things that happen in an instant.
But the pathology of thyroid crises reveals that a life-threatening catastrophe can actually manifest as a slow-motion domino effect. A perfectly benign decision like a missed levothyroxine pill on Tuesday due to an administrative oversight, or a routine CT scan with contrast ordered on a Wednesday that can act as the invisible push that causes a catastrophic multi-organ collapse by Sunday.
It's a profound reminder that the human body is never a static snapshot. It is a highly volatile, deeply interconnected system where every single intervention ripples across multiple physiological axes.
It forces you to question how many other seemingly routine medical decisions are silently initiating biological chain reactions right under our noses. The next time you encounter a clear-cut diagnosis, appreciate its simplicity. Because as this deep dive into the endocrine literature demonstrates, the most complex and lethal emergencies require you to look far beyond the obvious answers. Thank you for joining us today. Keep asking questions, and we'll catch you on the next deep dive.